are supposed to be a bit interactive. Unfortunately, my Zoom doesn't want to share the chat window with me at the same time as being able to see the slides, but there's only a relatively small number of people here this evening. So if there's any bits where I ask you, feel free to put your mics on and chip in with an answer. This week's talk is the D part, so disability. So we're going to do similar to what we've done in previous weeks, in that we're going to kind of illustrate a lot of the points using a case which comes in two parts, and that is going to include some bits about physics and neurophysiology, because they're actually quite important to managing this type of case. We'll talk a little bit about the management of some specific conditions and escalation to ITU, and then the same as in previous weeks, there will be breakout rooms then at the end that we'll go into for about half an hour and just talk through two further cases. So the case that we will talk through, so you're the F2 that's on for surgery, although you could equally be any training grade, I'm sure. And you get a bleep from the ward at 1 AM to say one of our patients has just had a seizure. Can you come urgently to see them? So a bit more background that you ask for over the phone is that, and you're told that this is a 29-year-old who is on the surgical ward after having had a lap appendix earlier on that day. And this bit of the case says, what information do you want to ask over the phone before you go? Is there anything else you would want to ask before you attended? So as I say, I can't see the chat, so if you just want to pop your mic on if you've got an answer and join in.
If they've got any history of seizures.
Yep, good.
If they've got any other comorbidity.
Excellent, yeah.
Are they still seizing, or when like how long did it last for?
Yeah, excellent. Anything else you want to know on the phone, or would you be happy then to just go and see?
Have they injured themselves?
Yeah, excellent. Okay, so all that really important things to know about. So in terms of the presenter complaint, some of this you will only get when you arrive. They probably won't be able to tell you this over the phone, but you want to know a little bit more about what type of seizure they're having. As you've already mentioned, things like whether or not it's terminated itself, whether or not it's still going, whether or not the patient's gone into the kind of the post-ictal phase afterwards, whether or not they've got any injuries. You want to know their OBS, and in particular you want to know their blood sugar. So normally it's one of the things that's quite good to just mention over the phone. Some staff on the wards will, depending on how often they see seizures, will have already done this for you, even by that point in time. But if not, it just gives people a chance to go and kind of find the BM machine and stuff, and then hopefully you'll be able to get that quite promptly by the time you arrive. Past medical history, as you mentioned, so whether they've got a history of epilepsy, alcohol history is another really important one to ask about. Whether or not this is usual for them or whether it's new. Oh, that's drug history, I think. So whether or not they're on the usual medicines, whether or not there's anything new that they've started on. Recent investigations, so in terms of their bloods, there are a few little bits and pieces that you might want to know. The likelihood is that for most of these patients, if they are surgical patients, will have hopefully had some bloods done that should be relatively recent. And then you can always ask them what's been done so far. So in this case, as I said before, 29-year-old male who's had a lap appendix done earlier that day. They have had they've had that done as an emergency procedure with an RSI under general anaesthetic using propofol, rocuronium, and then they've been run on volatile. For those of you who are not very familiar with anaesthetics and what any of that means, the RSI, as we talked about in the airway week, is just basically a technique that's used to intubate somebody relatively rapidly when they're having an emergency procedure done. And then propofol and rocuronium is a very standard set of drugs for that. And then volatile basically means that they've been given gas to keep them asleep rather than drugs for the operation. The history that you get when you arrive from the staff that have seen what's happened is that the patient has had a tonic-clonic seizure while walking to the bathroom, They have been seen to bang their head quite hard on the way down, and they have got a scalp laceration when you go and see them. The tonic-clonic seizure, they said, lasted for a couple of minutes and then self-terminated. The patient is a known epileptic with no other past medical history. They're normally on Keppra, but they haven't had their evening dose because they came out of theatre quite late and it wasn't given down there or in recovery. And they have been started on some tramadol for pain after their procedure, which again is relatively common. They have been feeling sick and they haven't eaten all day. So how are you going to assess this patient? So hopefully you're going to do an A to E assessment. Is there anything in particular that so I think we've done quite a few cases now where we've talked through the basics of an A to E assessment, but within that, is there anything specific that you want to look for with this particular patient?
Do you think about tongue biting with the tonic-clonic seizure?
Yeah. Good. So important in some cases in terms of thinking whether or not they've truly had a seizure. In this case, it might also be important because if they've bit their tongue and there's lots of blood in their airway, that's potentially going to compromise their airway. Good. Anything else?
Having hit their head, you're going to want to do like a GCS, check pupil sizes.
Yeah, excellent. The other thing I would also be thinking at this point in time is how reliable is that history? And does it look as though they've had the seizure and then hit their head, or have they hit their head and then had a seizure? Good. Anything else you would want to know about?
Probably want to check the surgical site as well. Make sure they've not done any damage there.
Excellent. Anything else?
At some point, you want to make sure they've not got any other injuries. Yeah,
good. In particular, I would be a little bit concerned about things like C-spine injuries, depending on how or where they've hit their head. So this is a young patient who you would hope wouldn't get a C-spine injury falling from standing, but I have seen it in older patients where it's been potentially neglected in the initial assessment because you're kind of very much focused on the fact that the patient's had a seizure, they've probably hit their head, but actually if they hit their head on like a bed or something like that going down, actually you can cause quite a lot of force on the C-spine. If you've got someone a little bit older, that can potentially be enough to cause an injury. Good. So yeah, so airway, thinking about I guess it's your general kind of airway assessment, but in particular, these patients are probably going to be post-ictal at this point in time when you go to see them, even if their seizure's terminated. So it's about thinking whether or not you can put them in the recovery position to maintain their airway, or whether or not they've got any other problems that might make their airway a bit more of a problem. So as you mentioned, having bitten their tongue. So in this case, this patient is, they're not speaking, they're snoring a little bit, they have bitten their tongue, and there's a small amount of blood in the mouth. Breathing is just a standard kind of assessment, and you would hope that in this situation, there wouldn't really be very much that you would find there, other than if their airway was compromised. So this patient seems to have good air entry when you listen, no added sounds, and they're sat to 94% just on room air. Again, circulation is just your kind of your bog standard assessment of that. This patient has got a high blood pressure, which is quite normal after you've had seizures, and a pulse of 118, which again is quite normal. But you were quite right, whoever said about looking at their surgical site, there's a chance that they might have done some damage. If it's a laparoscopic procedure, it's probably less likely. But if they'd had any kind of open procedure, you want to just make sure that there's not a risk that they've kind of pulled stitches and things open. They could be bleeding, so you just want to have a check of that as part of your circulation. And then I think you've already talked through quite nicely the kind of things you were thinking about in terms of your D. So that's things like your conscious level, pupils, and then blood sugar, which we'd already talked about. And then obviously there's E at the end, with probably not very much else than what we've already talked about. So in terms of this patient, you, from the end of the bed, see that there is not really any movement. But when you shout their name, they open their eyes, they shout no, bit sweary at you, but don't move their limbs. So hopefully you are familiar with the GCS score. So if with that little bit of information, what would be their E component score for the GCS, and what would be their V score? Anyone want to offer me for E out of 4 what they would be?
Would it be 4 for eyes?
So they
There'll
would be
3 for eyes.
Yeah, there'd be a 3 because their eyes are closed initially, and then when you shout at them, then they open their eyes. That'd be a 3. And what about the V?
V would be 3 as well.
Yeah, so you could, yeah, so you could argue it depends how relevant, I guess, what they say is. I think part of the point that this slide is making is that it's a little bit subjective in terms of measuring both their E and their V score, because part of it is going to depend on things like, if the patient's asleep, their eyes are going to be closed, aren't they? Like if you or I were here and we were feeling a bit sleepy, we'd probably just close our eyes, and then we'd automatically drop a point for that. And then, yeah, with the V, it's quite common to find patients that are really difficult to assess that because they might only talk to you in kind of 1-word answers anyway, so it's really difficult to kind of determine whether they're a 5, a 4 or a 3. But the bit that's a bit more important is the M component out of 6. So this patient, you give him a painful stimulus, his left arm hits your arm away, but the right arm doesn't move. So what do you think the M score would be?
Would it be
Any
5?
5, yeah, I think it would probably be a 5. I think this is probably them, so they're not obeying your commands. So to get a full 6, you have to obey commands. To get a 5, you need to localize to pain, which I think is what this is getting at. What do you think about the fact that one arm doesn't move? Do you think that's important or not?
Definitely important. You want to find out certainly if that's a new thing.
Yeah, absolutely. So you want to try and establish whether or not that's a new thing, whether or not it's just that the patient is choosing not to. So it might just be that they're left-handed and that's the natural kind of instinct. So if you got something like that, you would probably want to do a little bit more to just assess their neurology a bit more and determine what the problem is. In a patient who has had a seizure, do you know what that's called sometimes when one?
Todd's paresis.
Yeah, good. So it could just be that, but also they've potentially got evidence of a head injury and they've had a seizure. So you do just want to do a little bit more digging and not just ignore it. Where would you apply painful stimulus to a patient? Where do you apply it? Anybody? I think everybody does slightly different things for this.
Can we do
Is it
it?
Sorry, I heard 2 answers at the same time.
It's sternal rub.
So sternal rub is the one that very recently has been
Stopped.
been said
Discouraged.
now, yeah, not to do it anymore. I'm not quite sure of the reason. I would imagine it's probably something cardiac, maybe. I have once seen a patient who got a sternal rub and then cardioverted from an arrhythmia. So yeah, sternal rub used to be really good, but we're not supposed to do it anymore.
Trapezius or nail
Yeah.
orbital.
Yeah, a trap squeeze is normally quite good. And the other one that I find that's really quite good sometimes is a jaw thrust. So if you do a proper jaw thrust just behind the angle of the jaw, even if you do it on yourself quite gently, it's quite an uncomfortable feeling. So I find that one's generally quite good. So differential of a reduced GCS. So I guess we've had a couple of things, haven't we? Because we've talked a bit about seizures. Why else might somebody who you go and see on the ward have a reduced GCS? Just in general.
Hypoglycemia.
Hypoglycemia, good, yeah.
Could be post the anaesthetic.
Yeah, good. So anaesthetic and actually some of the other drugs that we might have prescribed as an anaesthetist.
Opioids.
Yep, good. So opioids are a classic one that get prescribed as post-op analgesia, and I think you use relatively standard doses, but actually there is quite a bit of variation in terms of how people respond to them.
Yep. They could be very hypoxic.
Yeah, good. So things like hypoxia can be reduced GCS, or also if your CO2 is too high. So if you have hypercapnia, you can also have reduced GCS. Anything else?
Any brain injury or space occupying lesion or
Yeah,
related to that?
absolutely. So anything inside your head that shouldn't be there. Yeah, so seizures, status, postictal. I think we said all of these, so well done. Yeah, good. Yeah, and then the E bit of your assessment, you have a quick look at the head. So you can see this chap is bleeding a bit from a scalp laceration on their right forehead, which the nurse has helpfully bandaged. The tongue bites that we already talked about. It says here not moving left arm. I think it said not moving right arm before. There is a little bit of bruising and swelling over that wrist, and the nurse has also helpfully done a temperature for you, which is 37. So we will talk, I think we've already probably talked about this mostly, but what does everybody think about AVPU scales versus GCS? Do you find it difficult to do a GCS on a patient? Because I do. I feel like actually an AVPU score, that kind of quick assessment of are they alert, do they respond to voice, do they respond to pain, or are they unresponsive? I actually find I use that much more commonly than a full GCS, just because it's much easier to do. And actually, it tells you a lot of the information you need to know. And I'm not sure that in a lot of patients, GCS adds very much more. So when I go to a patient like this on the ward, the kinds of things I'm thinking about are whether or not this patient's protecting their airway, whether or not we can safely take them to scan as they are, or whether or not we would need to intubate them to take them to scan. And actually, you're kind of thinking about those things if they're sitting in the voice area, and definitely if you get down to the pain or the unresponsive, it's kind of already told you what you need to know in terms of you needing to think about protecting this patient's airway a bit better. GCS though can be useful in certain patients, but it is a little bit more difficult to do. Pupils, I think we talk about in a bit, are very useful in unconscious patients. They can help you to certainly to narrow down your kind of your differential about what's happening with this patient who's unconscious. So patients who are having seizures, if anybody's seen inside the pupils while a seizure's ongoing, they're quite characteristic. You can see the kind of the dilating, contracting type of pupils. Patients who've got head injuries, you're obviously looking for unilateral dilated pupil, and that shows that you've got raised ICP. And if you're thinking about drugs, looking in, if you see pinpoint pupils, that's definitely an indicator that opiates might be a cause, although I would say that I have occasionally seen patients that have responded really well to naloxone, so it probably has been opiates, but actually their pupils haven't been that classic pinpoint, they've just been kind of small and a little bit sluggish. And then glucose we've already talked about, and we've talked about the focal neurology and lateralizing signs. So the Glasgow Coma Scale, this is just a bit of a reminder for everybody, but as I say, I think in a lot of patients, the important thing is kind of where they lie on the AVPU scale. If you are going to use GCS, I would say that the most important bit of it is actually the motor component, because the eyes and the voice are very subjective. And there was quite a big study that was done a little while ago that showed that even neurosurgeons are not very good, shall we say, at GCS. So it showed that there was, with the same patients with different neurosurgeons even, there was quite a lot of variation in terms of the GCS score that was attributed to patients. So if you are going to use GCS, the motor component is the most important bit, and that's the bit that's probably going to tell you more information about how that patient is doing. It's also the part of it that is probably the most important when you think about patients with bleeds in the brain, and their prognosis and what their surgical management is going to be. And this is just a reminder, because I think I, on the GCS, used to always get confused about in the motor bit, what was abnormal flexion, what was extension, when people used to talk about decorticate and decerebrate. So decorticate is the abnormal flexion, and decerebrate is that kind of abnormal extension where the hands kind of point outwards and everything extends. So this is just to think a little bit about why your motor component of your GCS kind of goes down and what that might mean. And so if you are awake and you're obeying commands, that means that your brain is functioning normally. To obey commands is actually quite a complex kind of whole brain response, if you think about it, because you have to have the signal that comes in, your brain has to interpret that, and then it has to be able to transmit that to other parts of the brain that then cause you to have a motor reaction. And actually, in terms of the obeying commands, you also then need to have the kind of the higher parts of that as well, in terms of you making conscious decisions about what you're going to do to react to that command. Which is why you then, if you lose some parts of that pathway, you do still react to pain, but you obviously react to pain in a different way, in terms of there's no longer those kind of the higher parts of the processing that mean that you can choose how you react to the prompts that you're getting. It's much more a kind of an automatic type of reaction to the painful stimulus that's given, and then as you go down, you lose all of those kind of polysynaptic type of processes first, so the much more complex parts of that kind of pathway, and then by the time that you get down to the abnormal flexion, the abnormal extension, that is basically a sign that you have only got the kind of the most primitive pathways in the brain that are still working. Yeah, so pupils we've already talked about. One thing I find quite useful, because I think, again, this is something that can be quite subjective in terms of grading pupils. The pen torches, I don't know if you've used them, but they normally have on the side of them the little scale that gives you the size of the pupils. It's sometimes quite useful to note down what size the pupils are, because it is something that you might get asked about by neurosurgeons, things like that. And we've talked about that. So pinpoint pupils. What would give you bilateral dilated pupils? So we talked about opiates is pinpoint. What are you thinking if you see bilateral dilated? Anyone done an A&E job?
It could be serotonin drugs overdose as well.
Yeah, good. Yeah, so there's if you're going to do ITU jobs, it's in a DGH type of setting. It's really, really common to get calls down to A&E to see patients who have come in with a low GCS and potential airway compromise, who have taken unknown drugs of some description, or the suspicion is they've taken unknown drugs, and actually having a look and whether or not they've got dilated pupils versus pinpoint can be quite useful in kind of determining what type of drugs it is that they're likely to have taken. And although it might not make lots of difference in terms of how you manage them initially, it just makes it a bit easier to kind of decide about things like giving naloxone and how much naloxone you're going to give them to wait and see a response. Because if they've got dilated pupils, it's much more likely they've taken something other than opiates. And then the one dilated pupil there, I'm sure the medics amongst us will be aware that there's other conditions that can cause this, but the time that we are most concerned about that in terms of ITU is if we know that we've got a head injury, because it's a sign that you've got increased intracranial pressure that you need to do something about. In fact, here we go, it tells us about what some of the causes are. Yeah, so on that list under pinpoint pupils, the other drug that you will see on ITU that's used in some ITUs more than others, but it's used relatively frequently now, I think, is clonidine. So clonidine is used as a sedative, as a painkiller, and that can also cause pinpoint pupils. Although I think if you were seeing a patient on the ward, you would be much less likely to see somebody who had had too much of that. And then glucose, normal level, says here 4 to 8, but actually I think you accept wider ranges for a lot of patients, particularly type 2 diabetics who may have very poor control at home. What would you give this patient if they were hypoglycemic? What are your
So
options?
I think every trust has their own guidelines, but normally 100 mils of 20% glucose.
Yeah, good. So you've got different options, haven't you, about what you can do. So you can give them oral, but I wouldn't give anybody like this oral, obviously, because they are they're already quite unconscious. You don't want to cause more of an airway problem. IM, it's talking about glucagon. Yeah, and then you're absolutely right in terms of IV glucose. Everywhere has their own guidelines. I think people probably develop their own preferences as well, just because you get kind of familiar with the doses that you would use for kind of the different concentrations of glucose. And just the one thing to be a little bit wary of is that the higher the concentration of dextrose that you use, although it means you give less of it, it is very sticky and viscous. And if you've got a patient who's only got a very small cannula, it can be really irritant to give them the higher concentrations of glucose. And so don't be afraid to just give them a bit more of a lower concentration. And then we'll talk through a little bit of physiology, just because I think if you understand the physiology a little bit better, it helps you in terms of thinking about patients. So this is a bit less the seizure kinds of side of things, and this is a bit more the head injury and the bleed side of things. But I think if you understand a little bit about the physiology of it, it makes it a little bit easier to think through and make sense of the things that you need to do to look after these patients. So again, if you guys go on to do ITU jobs across any type of hospital, really, you will come across neurosurgical patients in some way, shape or form. So either if you work at the bigger centres, you will see patients that come in from elsewhere and actually go to neurosurgery. If you work in the DGHs, you'll see these patients that come through the door or sometimes from the ward, and you have to kind of do the first basic bits of looking after their brain and preventing secondary brain injury before you then get them transferred on elsewhere. So this is kind of bread and butter stuff for ITUs. So this slide looks a little bit busy, but basically what it's talking about is the fact that your cerebral function, so the function of your brain, is dependent upon two things. So your brain needs oxygen and it needs nutrition. And in order to get that, it needs oxygen to be in the blood, and it needs the blood to be flowing in the brain. So you normally have about 750 mils of blood per minute will get to the brain. And what happens is, because of the fact that you've got blood circulating around your brain, that's going to cause pressure, with a certain degree of pressure within your skull. So the balance in terms of what can then get into your brain is determined by your MAP, so your blood pressure, and your intracerebral pressure. So you don't need to fully understand the ins and outs of that, but essentially what you do need to understand is that if there is too much cerebral blood flow in the brain, it will cause problems because your intracranial pressure will go up, which means that you then need to have a higher blood pressure in order to maintain the perfusion pressure for the things that are in the blood to get into your brain. And then if your cerebral blood flow is not good enough, then you're not going to get enough oxygen to the brain. So it's a really delicate balance, and you need to be able to maintain it in that balance. And so a lot of what we do in ITU is supportive measures to maintain that and prevent secondary brain damage. So your blood flow is normally, in a healthy brain, auto-regulated between blood pressures. So if mine or yours MAP is anywhere between about 50 and about 150, our brain will do, the blood vessels in the brain will do lots of clever things to keep that cerebral blood flow at a constant level, regardless of where our blood pressure, our mean arterial pressure lies. However, you lose that in an injured brain. You lose it quite early on. Other things that affect the level of cerebral blood flow in the brain are your amount of oxygen, so the blue line on this chart, and the amount of carbon dioxide in your blood, so the orange line. Now, what's important to know about this is that if you look at that blue line, if your PaO2 on your blood gas drops below 8, then what happens is your vessels in your brain dilate up to try and deliver more oxygen. So you run into problems. So it's really important that in patients with head injury that we keep an eye on what their PaO2 is, and that we keep it at least above 8, if not a little bit higher, so probably a bit more, kind of about 10. And then with CO2, kind of the opposite happens. So the relationship there is linear between the amount of CO2 in your blood and the amount of blood flow. So basically what that means is that if your normal PaCO2 should be somewhere between about 4.5 and let's say 6. So it's down at that kind of bottom left part of that orange line. You can see from that orange line, it's a relatively steep upwards gradient. So actually, if you allow your PaCO2 to increase, even only by a small amount, your cerebral blood flow increases quite substantially. So it's also really important that we keep an eye on that. And so some patients who get a head injury, even if your concern isn't necessarily that they are not protecting their airway in terms of their there's nothing kind of obvious in terms of snoring, grunting, that kind of thing. You still are thinking at the back of your mind about whether or not that patient is able to adequately keep their oxygen level and their CO2 level at an acceptable level. And if you think they're not, then that's another indication for intubating that patient early on, so that you then on a ventilator can control these things a lot easier. And these are just some slightly more complicated ways of talking about what the brain does, but essentially metabolic coupling is just all to do with what your brain does in response to its normal metabolism. So it metabolizes things, it creates different substances, and then that also has an effect on cerebral blood flow. One of the reasons that that's quite important in patients, for example, who are having seizures, is that you, if you're having a seizure, you're going to increase the amount of oxygen your brain needs, and you're also going to kind of undergo lots more metabolic change there, lots of activity. So again, you'll increase your cerebral blood flow. And then in terms of temperature, it's another really important thing to control in these patients, because your the CMRO2, which is the amount of oxygen that your brain is using, again, changes quite substantially with temperature. So it's something else that we have to really keep an eye on in these patients. And why is all this important? So it's all important because of intracranial pressure. So you may or may not remember from school, from medical school, something called the Monro-Kelly doctrine. But this is basically talking about the fact that within your skull, which is a fixed box, you have contents which are predominantly brain, but you have some CSF and some blood. Because it's a fixed box, the size of that box cannot change. So the pressure will change if the volume of any of those three things changes. And what you're particularly worried about is the fact that your CSF and your blood are normally only very small components of that. So even a relatively small increase in either of those two things will substantially increase the pressure in your brain as a result. And you can compensate for that a very, very small amount, but not very much. And then once you hit C, the point on that chart there over on the left-hand side, then you run into real problems. You cone. So this is just the kind of the basics about what we would do in critical care for these patients. So as I said, we would try and keep the PO2 above 10, control their cerebral perfusion pressure. So that means that we would support their blood pressure in order to maintain that. We do things to try and reduce their intracranial pressure. So that's keeping their CO2 normal, or if anything on the low end of normal, making sure we do really simple things to improve the venous drainage. So that's things like not having anything around their neck that's going to constrict them, keeping everything in a neutral position. We keep them slightly head up, so 15 degrees. Osmotherapy is either hypertonic saline or mannitol, which we normally only give if we have evidence that intracranial pressure is significantly raised. So that will be clinically looking at if you've got a blown pupil. Those of you who go and work somewhere like James Cook and you see these patients on ITU may have had a bolt put in by the neurosurgeons, which actually measures ICP. Reducing CMRO2, so that's the metabolic demands of the brain. So that's giving them things like sedation and analgesia. If they're intubated, paralyzing them with muscle relaxants and aggressively treating any pyrexia. Nutrition and glucose control is really important to that. Yeah, and then monitoring. So when it talks about bolts, it's literally what it sounds like. The neurosurgeons, they come and they put something into the skull that then measures intracranial pressure. So this patient, you continue to assess them. They have another seizure, which is tonic-clonic, and this time is not terminating. And handily, his cannula's fallen out while he's having his seizure. What would you say the diagnosis is now?
She's got status.
Yeah, so status epilepticus. So actually, I think the definition of this has changed since I was at medical school. So I think it used to be longer, but now it's anything more than 5 minutes without return of consciousness. Or two or more seizures without kind of an intervening period of full neurological recovery to GCS15 or whatever was normal for the patient beforehand. It is a medical emergency because it's well proven that faster seizure control is associated with better outcomes. And I think the thing that you forget is that actually seizures of any description do have a really high mortality rate, like 10 to 15% mortality rate is quite high. And it is something that actually we can do something about in the majority of people. So goals of treatment now would be resuscitation to prevent secondary brain injury and maintain cerebral perfusion pressure, which we've already talked about, terminating the seizures because that's going to decrease your cerebral metabolic rate, and diagnosing and treating the cause, which I think we'd already decided there were several things that could potentially be contributing to it for this patient, and then treating any complications. So for example, trauma. So this is basically what we'd already talked about in terms of ABCs. They're not really very different, but it's just about thinking about what's the safest thing to do for the patient, because things were a little bit different if you've got someone having a seizure to if they were just plain unconscious, because of the fact that although your airway adjuncts and things might be useful, there is a risk of injury both to them and to you of trying to put them in while the patient's seizing, and it would certainly be impossible to intubate a patient, I think, while they were seizing, or it would be certainly very, very difficult. But what you can do is try and optimize their oxygenation as best as you can. And yeah, again, it says provide ventilatory support, but I think that's very difficult to do in a patient who's actively seizing. And then think about your access. So again, that's quite tricky in seizing patients. And these are one group of patients who you might think about putting an IO in. Hypoglycemia we talked about, and then yeah, just don't forget your alcohol history, because it's thinking about whether or not you also need to give thiamine to them as well. So terminating the seizures, so we'll just briefly talk through this. So hopefully everyone's aware that first line is benzos, and that largely depends on what route you have got available to you. So ideally in a hospital you'd have IV access and you'd be able to give lorazepam. You can also give midazolam, and you might find that on ITU occasionally people will give IV midazolam instead of lorazepam. It's just because some anaesthetists are just far more comfortable using midazolam, because it's what they would use for sedation. And I don't think it really makes very much difference. And then in terms of second line, it's always traditionally been phenytoin. But actually there's been a bit of a shift in thinking, and it wouldn't be my preference, but that's just because it's not what I'm really used to giving. So my first second line choice would be Keppra. The dose actually on here is a little bit wrong. I think this is kind of a little bit old. So Keppra is a drug that can be really useful, but you do need to give it in proper loading dose the first time you give it to someone that's in status. And actually it can be up to 60 milligrams per kilo. So I think it's up to 4.5 grams that you can give. And what commonly happens is people just give it in a dose that's too low. They give a kind of about a gram, which just isn't going to be enough for a lot of people. So it's largely what you're comfortable with, what you know how to give. But the one thing I would just say with caution in phenytoin is that phenytoin is also quite a potent anti-arrhythmic. So please do make sure if you use phenytoin outside of a monitored environment, outside of ITU, that you get some monitoring or some telemetry for that patient while they're having it, because you can run into problems with it. And then this is basically that, but what this is showing is that these are definitely patients where you will not be frowned upon from the wards for calling quite early on to go and see these patients. And if you're on ITU holding a bleep, you will get called to them relatively early on. That's fine, because you can arrive, do a little bit of information gathering while the medical team are giving those first few things to the patients. And then if you're getting down to the point where you have seizures ongoing for kind of 30 minutes, or if you've given a couple of these drugs and things aren't terminating, then these types of patients are going to need to be intubated and come to ITU. So some of the things that we use to intubate are in themselves anti-epileptics, and I have seen patients that have failed to respond to all of the initial sets of drugs that are given, but then do stop seizing as soon as they're given either propofol or thio. And then, yeah, thinking about the underlying cause. So in this patient, we knew that they had a history of epilepsy and they hadn't had one of their drugs given, naughty anaesthetists. Hopefully that should never happen. Thinking about infections, there is a chance that they could have an infection, but there's not really very much that would be pointing you towards that. Thinking about increased intracranial pressure, so if there was a head injury there underlying as well, do they need to go to the neurosurgeons for decompression? And if you see patients in maternity, thinking about eclampsia, so that's one place where magnesium is also used in blood pressure management very early on. And then rare things are other types of drugs that you might have had. And actually in this patient, if they are an epileptic and they're on tramadol, there are some drugs that lower your seizure threshold, and tramadol is definitely one of those. So I normally wouldn't give tramadol to an epileptic. Nefapam also does it as well. So just look at what other drugs they have recently been prescribed, because that might also be your answer. So this we've mostly talked about. So trauma we've talked about, and then the left arm, whether it's injury or TODS paresis. Aspiration is relatively common, I think, in patients who have fits. It doesn't in itself, if it's been a small amount, necessitate intubation, but it's certainly one of the reasons that we would intubate patients, is if we're concerned that there's a big risk of that. They can get pulmonary edema as a result, they can get rhabdomyolysis, and they can get hypothermia. Yeah, and then who to speak to, so critical care, neurologist, plus or minus neurosurgeons. And again, I think I've already mentioned most of this, but the types of patients that we definitely want to hear about are any patients who you think there's going to be a problem in terms of the airway management. So whether that's that they aren't able to maintain it. So it might be that patients had a seizure and then they become postictal, and it might become obvious that they're going to just come around. So it might be from their history that you know that they normally have about an hour postictal after a seizure. So you might be able to put them in the recovery position to maintain it themselves. But definitely worth getting an anaesthetist to come and have a look. Anything that isn't, so if your treatment's not working, it's to facilitate investigation. So patients who need CT heads quite commonly need to be intubated for that. And then anything in terms of traumatic brain injury. So this is just to reiterate that the D assessment itself is simple. But don't forget to do the ABC first, because actually it's the A that's the patients are going to run into problems with, even though it's a D problem that's underlying it. And then, yeah, in terms of status, using the drugs you're most comfortable with and involving ITU early.